I'm going to talk about SGRT and some clinical applications. We got our first Vision RT 2 years ago at the Northside Atlanta Clinic. We primarily bought it for all the lectures you've been hearing this morning for left-sided breast lesions and breath hold. And I just wanted to talk about our learning curve a little bit and how we expanded the use of SGRT to virtually every treatment site. I have no conflict of interest, but Northside Hospital is a reference site agreement with Vision RT. And these are my objectives for the talk. I'm going to skip a little bit of the first one because we've gotten a good background on how Vision RT is used to decrease cardiac and lung dose for left-sided breast lesions, but that is the main reason that we purchased our unit. I'm going to talk about how Vision RT decreases both the time of the breast setup for right and left breast lesions and has really improved our accuracy. Vision RT has also improved the setup for other sites, such as extremity lesions, many other disease sites, and you're going to keep hearing this over and over again. It is improving our accuracy and throughput. And they say at a talk you should give 3 points, and that's the main point from my talk. Accuracy, throughput, and no marks. The patients love that. And finally, talk about the learning curve of Vision RT in our department and the impact on, again, less shifts, detection of any physical body change, weight loss, seromas, and overall improvement in treatment. So we first used our Vision RT, again, for our left-sided lesions. There were many articles that were being put out showing improvement in cardiac and lung doses and the impact that this can have on patient survival. So we started in our Atlanta center, and I have a lot of patients at a satellite center about 15 minutes away that were breast patients. And we would do our 2 plans at first. We'd do one with breath hold for our left-sided lesions, and then a free breathing plan. And we saw that over a third of our patients would go from not passing the RTOG 1005 criteria to passing it in terms of their cardiac dose. And then we found with an article saying that young patients, especially if you can decrease the dose of the heart by 5%, they have some increased improvement in survival and less cardiac disease. So then we were doing on more of our young breast patients. So up at Alpharetta, I have these young patients and I'm simulating, and now for the first time I'm really looking at their mean heart dose. I'm like, oh, we got to get it up here, because we'd sim them and tell them to go down to main campus, and some of them would and some of them couldn't. So then we expanded to our satellite facility. And what's interesting about this, it's a small facility. It just has one true beam. So instead of having multiple therapists rotate through and just one machine that just had breast cancer and stereo, we were exposed to all disease sites. And our therapists became very good at using the Vision RT, and we started to evolve this thought process. So this is our left breast, and Liz did a great talk on this morning. We would get 2 scans, the breath hold and the free breathe, and use the free breathe for initial setup, and then go into breath hold. And originally we are running, and we still are a lot, running plans on both, to see that there is an advantage for the breath hold. Also of note, expanding this to our right-sided lesions, and we'll routinely get 2 scans for the right-sided lesions as well, because especially if you're doing a 3-field with a superclav, we can significantly lower the lung dose, and we found some patients that do not pass Quantec requirements for their V20 in lung, and they would pass it if we did it with breath hold. So here's our breast setup, and Again, a patient comes in, we have their breath hold scan, as well as the free breathe. We found significant benefit to setting up to the free breathe. This enables us to get her in the free breathe position accurately, quickly, and then go into breath hold. This way too, our patients, we're not using marks for 3-field. We set up to single ISO, and they do extremely well. The way this kind of evolved a little bit is we had a patient that originally we were just doing the breath hold Vision RT, which I don't recommend. But so we didn't have the original marks on the, we had the marks on the patient and would set up kind of the traditional way with marks, and the patient lost her marks. And then we were trying to get her to do the breath hold, and we couldn't get her into that position. We imported the free breathe scan that we had and set her up like that. And so from then on, we've just been using the free breathe for setup and not worrying about the marks. This is the patient Liz had this morning whose expander dropped, and again, we would not have noticed this difference until we did another film day probably. We have seen a lot of changes in external anatomy that have helped tell us, hey, we need to go back and replan this patient. Sometimes the seroma will either collapse or grow extensively, and if we can see a big enough difference that it changes our Vision RT, that's a clinical implication that we need to go back and re-sim that patient. So as far as our breast patients, we are seeing decreased time for setup, which always helps your throughput. Definitely less shifts. We're making sure the soft tissue is in position. Another benefit is when you have patients that their breasts are kind of floppy, and you can make sure they're in the exact same position each time. You can detect anatomy change, like a seroma growth or an implant falling down, which has only happened that one time, but that was huge. What the therapists love too is the SSDs are taken from outside the room, so they're not going back in the room, checking the SSDs, coming back out. That saves a lot of time, and they love that. And what we also love is it also detects the pre and intra-treatment motion. And our therapists were just talking about how now we catch people because they don't think you can see them, and they'll scratch their arm, move when you walk out of the room. And a lot of times too, if you're looking at the monitor and they look like they're not moving at all, but we have found out in many treatment sites that it's changed on our Vision RT, so it becomes very important in our stereotactic patients. You can see movement on the Vision RT that you can't see visually with your eye. And then, again, no marks. So this is where our therapists have really embraced this and made our program so good because they're thinking out of the box. When there are problems, and again, it's a little bit of a learning curve. It's frustrating at first. Sometimes things don't always work, but if you have great therapists that are thinking and challenging themselves, you can find solutions to every problem. For instance, we had a patient and her pigment was very, very dark, and it wouldn't register on our Align RT. And therapists didn't come to me or anything. They took care of it themselves. I saw the patient for a weekly visit, and she was covered with a white paint pen, and I was like, oh my gosh, what's happened? And they fixed it, and the Align RT was able to register because of they could kind of color her in with a paint pen. And so think out the box, and this can work in every area. So we were using it on every one of our patients at our satellite facility, and this is just a bone met patient, and but it helped set it up every time. It's an extremity. Extremities can kind of move a little bit. This is the accuracy on the left, and that's only 0.2 is the higher mark. So he set up with no shift basically every time, and so they visually look, make sure He's on the table, it's lining up to the lights, and they come out of the room, bam, no shift, and we can treat him. This is a very complicated patient that had a melanoma, and the peripheral area was actually the post-op tumor bed, which was very shallow. So that I wanted to treat with electrons, and then it went deep to all the lymph nodes. So that was an electron field matched up to an IMRT field. And I would not have felt confident setting this up without the Vision RT, but I was fine with this juncture line between them because I knew he wasn't moving. Also, it's set up perfectly. You can just move his arm into position and make sure it was in the correct area. And you can see this would be a little bit difficult just doing with films and orthogs. It's just arms can rotate, move more forward, backward, and it was a really nice setup. So other treatment sites, I think we've had a talk yesterday about SBRT, and we use it to for initial setup. Then you get your cone beam, and then sometimes the doctor hopefully is right there by the machine, and sometimes you're calling them and they don't walk back fast enough. So at least okay, this patient isn't moving from the time I did the cone beam to the time the doctors checked it. So that is great, as well as intrafraction motion. And Dr. Waghorn's talk yesterday talked about the stereotactic. You can also use it for head and neck patients if you cut out the mask and make sure they're in initial position correctly. With our frameless system, we would not feel comfortable using the frameless stereotactic without the Align RT, just because of motion. We're setting up to a very small area. And then there are times when the Align RT didn't work, and this is what we're trying to still troubleshoot. So this was a patient who had breast cancer and radiation, and then unfortunately got an angiosarcoma in her lateral breast, and she's getting pre-operative treatment to a bed around her sarcoma. I thought this was going to be a great setup with the Align RT. Her breast was very floppy and mobile, and so I thought this was going to be really good to make sure I had the exact area every time, and we cone beamed it for verification too. Unfortunately, one of the limitations, and we found this out, that her body was too close to the imaging, and so it wouldn't register. And if anybody out there knows how to fix that, let me know. But so this is something we said, okay, we need to have her more flat and have the beam come in from the side. This is another patient that he has a very large sarcoma extending from the pelvis all the way down to his knee, and it's a very complicated beam, and it had to be half beamed and very minimal lymphatic sparing of the skin. And so I really wanted the Align RT to make sure this was an accurate setup. Unfortunately, he was in a lot of pain. There was a movement. He couldn't hold still. The leg would swell and change on a daily basis. So this is a limitation to the Align RT. But basically, every other site, from head to toe, we have seen a significant advantage. There's a recent article out about pelvis, and that maybe there's not such a benefit. Well, of course, for a prostate, you're going to use your cone beam, you're going to look at internal structures when you need to, but still the Align RT starts you out at a good place. Again, it makes it a little bit quicker because you're not making as many shifts from the external, at least. Again, SSDs you can read from outside the room, and if marks come off, it's not the end of the world. And so this is just, again, think out of the box, challenge yourself, and I really credit our therapists and physics department for evolving this process, because now we want it on everybody. Thank you.